Hello, everyone. Thank you for being here. I know it's a difficult time of the day. Now, we're going to have a little presentation about corneal ulcers and discuss a little bit about the superficial, the bad ones, and the ugly ones. And the outline of the presentation is we will initially have a brief introduction and discuss some basic principles. We will discuss a little bit of the equipment and see if we're getting the most out of what we have. Then we will move on to the canine corneal ulcers, discuss the superficial ones, the deep ones, and the complicated ones. Touch a little bit on feline corneal ulcers. Do we just treat it as a small dog? Is there anything that we need to be aware of and be more particular? And then for the brave ones that are still with us at the end of the presentation, we will have a Q&A section and we can discuss any questions. Feel free to write any questions at the chat, but probably we will leave everything for the end and then we can come back to any of the slides and discuss everything at the end, if that's okay. So just a brief introduction in regards to the cornea and the corneal surface and the bulk of the cornea. It is important to mention that more than 90% of the cornea comprises the cornea stroma. So the bulk of it is the corneal stroma. The epithelium is this tiny little layer at the top. Hopefully my pointer is showing everything okay. And then back down here in close proximity with the aqueous humor, we have the Descemet's membrane and the endothelium. But as you can imagine, if we've lost all of this, pretty much nothing is holding the cornea together. So we are always happy to see that just the top part, the top layer of the cornea is affected. When it comes to non-complicated corneal ulcers, so the ones that are affecting the epithelium or the epithelium in the superficial part of the stroma, these should resolve within a period of 7 to 10 days with symptomatic treatment. Now, moving on a little bit on the equipment, when we're discussing about corneal ulcers or when we're looking at them and examining a dog with a corneal ulcer, one of the most important things is magnification. And I'm sure some of you will have access to a slit lamp and good magnification. This provides a magnification of 10 or up to 16 times. It is a brilliant piece of equipment, and I do recommend it for those ones that for you that you want to grow your knowledge a little bit. It will literally open your eyes to a different world. But if you don't have a slit lamp available because of cost restrictions, or if your practice doesn't want to invest in that, I'm sure that all of you will have a direct ophthalmoscope, and some of them are really, really good. They do have the slit beam as well. They have a cobalt blue filter. They do have all different shapes. So apart from assessing the fundus and the retina, if you change the little dial there that everyone is afraid of changing because the equipment might break, if you change this dial from 0 to +20, then the ophthalmoscope is coming outwards from the eye and it is focusing to the surface of the eye. So changing the dial to 20 will give you some degree of magnification. Definitely not similar to the one that you will get with the slit lamp, but it is a great piece of equipment if you have nothing else. Now, we always check the tear production. I cannot stress that enough. You should always stock some serum tear tests. It is important to do that before you put any drops in the eye, because it is a critical part of the examination, a critical part of the treatment as well. We also need to make sure that we have adequate anesthetics at the practice. Proximetacaine is the main one that will be very, very useful for you to examine the patient. Dogs come with a severely painful eye, and after a couple of drops of proximetacaine, you will see that the eye opens up nicely, and it will help you to examine even those that are quite difficult on presentation. And for the ones that you need to provide some analgesia at home, I would definitely advise to have some atropine in stock. There are certain contraindications, so glaucoma or lens laxation. In these cases, we shouldn't use atropine, but for straightforward corneal ulcers, just a one-off drop will make a significant difference to the patient's comfort and to the owner's appreciation of that. In terms of the diagnostic dyes, the most common one that we have in practice is the fluorescein one, and personally I prefer the strips because they are much easier to use in terms of flushing out with sterile saline. If you use the pipettes, that's acceptable, that's absolutely fine, but it will require much more flushing to make sure that you will get rid of the dye that is pulling to the surface of the eye. So the strips will make your life easier, and they are really easy to use as well. So I definitely recommend those if you don't have them at the practice already. And then in terms of sampling and diagnostic procedures, using or having a cytobrush in hand is very helpful. Having some swabs or sterile cotton buds is also helpful, but the cytobrush will give you a much better result on your cytology. Obviously, be a bit mindful if you have a very fragile eye. We don't want to be touching a desmetocele with a cytobrush, but in any other situation, after you apply some local anesthetic, you can use that and you can assess for on cytology if you have bacteria, if you have rods there, cocci, and guide your treatment plan a little bit better. Now, before we examine the patient, and I cannot stress how important that is, the most important part is the signalment and the clinical history. I do appreciate that most of you only have 15 minutes to examine dogs and cats and any species. Some of you might even have 10 minutes or less, but getting the signalment right and the correct clinical history will save you a lot of time of your examination. If you ask the right questions, if you approach the patient correctly, in most cases you will have your diagnosis even before you examine the dog. And these creatures are pugs and brachycephalic dogs, cover the large majority of the cases that we see. I'd say probably more than 60 or 70% of our cases are brachycephalic dogs, and they do have certain problems with entropion. They have big bulging eyes. They have poor corneal sensation. So these are things to consider when you are presented with a breed like that. Clinical history is important, and discussing the onset of the problem, if it was acute onset or if it's something that has been grumbling on for months and the owner just decided that now is the time to bring the dog to you. The chronicity of the problem, is it something that the dog has been receiving medication for some time and now it's not as good as it was and something has changed, or is it something that it's the first time that the owner noticed it? And of course, previous eye problems can guide you on if this is a recurrence of the same eye problem or if it is something different. So taking a good and thorough clinical history is important. Before we examine the dog, it is important to do the hands-off examination. I know it's a little bit difficult now with COVID, but hopefully things will go back to normal. And we assess the dog with a hands-off examination. We assess the dog and the cat when they are in the consultation room with us. And we assess them from a distance for obvious things that we can spot, see how they move around. If you have a blind dog, you will bump into objects. If you have a dog that is extremely blepharospastic in one eye, then this is something to guide you that there is a problem there. Or might be blepharospastic in both eyes and the owner hasn't noticed that. There might be some discharge around the eye, but also make sure that you have a look around the other areas. So this dog had a neurogenic dry eye, and the most important finding to guide you is the ipsilateral dry nostril. And then once you've done these things, consider the signalment, the clinical history, and the hands-off examination. You start with your standard examination as you would do with any other cases. And an important thing when you take an animal either out of the basket or you put it on the examination table is to assess for conformational abnormalities, because using any dyes, using any local anesthetic will change the conformation of the eyelids. Even applying saline will make the animal blink a bit more, and it might create a problem or what appears to be a problem at the time that wasn't there. Straight from the direct examination, we can see that this cat does have a little bit of entropion, and in this case, we did apply some fluorescent dye, and you can see that the entropion matches the area of the corneal ulcers. So definitely, conformational abnormality is a problem here. Another important thing is to assess if the patient can blink. Sometimes we are presented with a case with a corneal ulcer, and for example, this case had a myotic pupil and a superficial corneal ulcer. But when we, sorry about that, doesn't seem to want to play. It was supposed to be a video here, but we're having some technical problems. Sorry about that. So you should assess if the patient can blink, because sometimes we might have facial paralysis and the animal may not have the capacity to blink, which will cause dry eye and evaporative disease and secondary corneal ulceration. So this is also important. Assess for any aberrant eyelashes, either distichia or ectopic cilia, and some of them are pretty obvious. In the majority of the dogs, they will not cause significant problems. However, in dogs that we have corneal surface disease, especially close to the area of the eyelashes, these are probably causing a problem, and we should do something to address these as well. Assess the tear production again before we apply any local anesthetics or any saline or flash the eye or do anything. Assess if the tear production is good, so that we have this baseline and we know how to be guided with that. And after you apply some local anesthetic, always check what is happening under the third eyelid. This is the most common area for foreign bodies, something to be stuck there and cause problems, recurrent problems. We do see cases that have been having problems for months upon months, and there is something small like a grass seed or a small piece of material that is causing corneal irritation. So this is definitely important. Now, the easy ones, the superficial ones, are, as we discussed, the ones that are affecting just the epithelium and or the superficial stroma. And you can see now here we're just missing a little bit of the epithelium. We have a bit of underrunning of the fluorescent dye there, and we do have a small opacity there. These are straightforward, non-complicated corneal ulcers that with symptomatic treatment, as we discussed, preventative antibiosis, the antibiotic of choice would be chloramphenicol in this case, using it 4 times a day alongside some sodium hyaluronate-based tears. If you have Riemann-Diess dogs, that's fine. If some of you have something different like Hycosan or Clinitas or Cystane, that's absolutely fine. Just make sure that the owner knows that this is an off-license use, the same as chloramphenicol. Provide some analgesia, of course, systemic non-steroidals, and a drop of topical atropine will help to alleviate most of the discomfort. In some cases, a bandage contact lens will help with primarily with the animal's comfort, not necessarily help with the healing of the ulcer. But for very painful dogs or cats, you can consider a bandage contact lens as well. So what happens for the superficial ones that are not healing, and why are they not healing? There are a few things to consider that we've already discussed some of them. We look for distichia. We look for entropion or ectropion. We look closely for ectopic cilia. Dry eye can delay the healing of a corneal ulcer. Foreign bodies under the third eyelid or on the corneal surface will delay the healing. But if you're presented with a middle-aged or older dog with a persistent corneal ulcer that is not improving on symptomatic treatment and has none of the above, then maybe you are dealing with a spontaneous chronic corneal superficial defect, SCEDS in short. And these are cases where the epithelium is not adhering properly to the corneal stroma, and due to a hyalinized zone, and we do need to do something to get rid of this hyalinized zone and try to stimulate the healing of the eye. And SCADs will need a form of mechanical debridement. You can either use a cotton bud if it's the first time you're seeing the dog and it is just a superficial corneal ulcer with some underrunning of the fluorescein, using a cotton bud and starting some broad spectrum antibiosis, as we discussed, is acceptable. The success rate of the cotton bud is probably around 40 to 50%, so not great, but definitely an advisable and a very good first line approach. Then, if things are not getting better within a period of 7 or 10 days, we can consider a grid or a punctate keratotomy. Depending on which study you're reading, we're looking at a success rate of 60 to 70% for those. And then if some of you have access to a diamond burr, this has a slightly superior success rate. Again, depending on the paper you're reading, 70 to 80% success rate within a period of 2 to 3 weeks. And if you have a dog that has had some of the above, you're 4, 5, 6 weeks down the line and nothing's getting better, probably a superficial keratectomy is the way to go forward. It has a brilliant success rate, I would say close to 100%, but it is something that requires general anesthesia and the use of an operating microscope. So usually referral would be required for these cases. Symptomatic treatment, as we discussed before, preventative antibiosis, sodium hyaluronate-based tears 4 times a day, analgesia, and abundant contact lens, and reviewing the case in 10 to 14 days after the punctate or grid keratotomy or the diamond burr debridement is indicated. The one thing to stress is that diamond burr debridement has been associated with the development of a melting corneal ulcer, so this is something to always have in mind. Always aseptically prepare the eye and sterilize your diamond burr, and ideally make the owners aware that there is a small risk. The majority of the cases will have no problems, but there is a small risk that we might have complications. So it is always good to prepare them for the worst, just in case. In regards to the keratotomies and the diamond burr debridement, these are inexpensive procedures, and if you're familiar with the procedure, you can do them either under sedation or even with local anesthesia. Some dogs are really, really good with that. They can be performed by you, and they have an adequate success rate, as we discussed. But I cannot stress that enough. They should only be performed for superficial and non-complicated corneal ulcers. Anything that is going deeper than the epithelium should not be debrided or graded. You are risking causing more harm than good. So we do have these cases of mid-stromal ulcers that have been debrided with either a grid keratotomy or a diamond burr debridement. This is something that can cause further damage and complicate things. So we only reserve these options for the superficial ones, and especially the non-healing corneal ulcers. Now, moving on to the bad ones, the one that, as we can see in these pictures, we are missing part of the stroma or most of the stroma. And usually when this happens is due to a complication. And the complication in most cases is something that should be relatively obvious to us. If there aren't any complicating factors, the ulcer should heal on symptomatic treatment. So we need to, if we're presented with a deep corneal ulcer, we need to look why and find out why this happened. So as you can see, the eyelid mass here does match the area of the corneal ulcer. So we know what is causing the problem. We just need to get rid of that to try to help with the healing of the ulcer. Dry eye, as we discussed, this is a classic presentation. We have a lot of dried discharge around the eye and a very deep corneal ulcer extending deep down to Descemet's membrane, and it can't heal because of the suboptimal tear production. No matter how much the eye tries to heal it, if it cannot support itself with the necessary nutrients, then the ulcer is not going to resolve. Trauma, again, we have a direct view inside the eye. You can nicely see the iris through this desmetocele. whereas the rest of the cornea is fine. These are true emergencies, and we do need to be worried about these. Foreign bodies, again, not very surprising. A pug with a foreign body and a deep corneal ulcer there, and a superficial one in the other eye. Usually they present with one problem, but multiple problems are not uncommon. And then infectious agents can cause malacia around the area of the ulceration, and they do tend to grow in a circular pattern and destroy more of the cornea and grow deeper. So again, these require urgent attention. So how do we manage these deep or complicated corneal ulcers? It is important to stress to the owners that these cases are critical, and the eye can deteriorate and it can even perforate in some cases. So we do need to restrict the exercise for these cases, not necessarily hospitalize them and cage rest for every deep corneal ulcer, but we do need to make sure that the animals are not running through bushes or running off the lid, playing roughly with other dogs. For the deep ones, that obviously not for this case, this is a true emergency, but for the deep ones that you are dealing with medical management, with intensive lubrication, targeted topical antibiosis based on your cytology or your culture and sensitivity, and systemic pain relief. For these ones, you do need to exercise restriction for some time. All these are slowly healing corneal ulcers. You wouldn't expect these to heal within a week or 10 days. This, if we don't choose to go ahead with a surgical repair, we're talking about weeks or months that the eye will be fragile and will be repairing itself. So the owners need to be aware about that. And then surgical options in the form of a conjunctival graft, corneoconjunctival transposition, use of collagen scaffolding materials like Biosys or ACell, or corneal transplantation. All of these have a very good success rate, assuming that we don't have an active infection or we manage the infection at the same time. Personally, I don't like using third eyelid flaps, but as a last resort, if the owner can afford nothing else, it is an option that can be considered. Now, a little bit more information about the melting corneal ulcers and why it happens. In most cases, it's because of a pathogen. Of course, Pseudomonas is the most common pathogen, but beta hemolytic streptococcus can also cause this problem. And this is where it is important to use your cytology, because we usually assume it is Pseudomonas, but if we make this assumption and we start the dog on fluoroquinolones, and we do have indeed a streptococcus there that is not sensitive to exocin or I'm forgetting the other name. Sorry about that. Anyway, and if it's not sensitive to the fluoroquinolone you choose, then you will end up with a more severe problem. Breed predisposition is a factor. Brachycephalic dogs tend to be prevalent to developing melting ulcers. Sometimes when we have a deep corneal ulcer and the animal is trying to repair the problem, just an imbalance during the healing and infiltration with neutrophils can lead to excessive collagenolysis, and this is what we call a sterile melt. And in this case, you will find no bacteria on your cytology, or the use of topical corticosteroids in already infected ulcer or a complicated ulcer can lead to a melting corneal ulcer. And these are cases that, again, we need to minimize exercise. This is relatively superficial, but you can see that it has this rim of melting. It doesn't look nice. These are cases that require intensive management, and they do require hospitalization as well. So the intensive management is primarily focused on your serum. serum drops, we start with usually every hour, and the same for the targeted antibiosis. We start alternating these drops for the first hour in conjunction with lubrication and analgesia, either non-steroidals alone or non-steroidals combined with opioids. And we reevaluate these patients after a couple of hours to assess where we are up to. And then if we can see that the melting is starting to arrest, then we can reduce the frequency to potentially every 2 hours, and then review the patient in probably 8 to 10 hours to assess where we are up to. In regards to serum, the best way to get around it is when you have a large dog for castration or a spay, just ask the owner if you could take some blood as a donation for other patients that might need it. There is nothing more stressful than being 6:30 in the evening, having an emergency coming through the door that requires serum, and you have nothing in stock. You cannot hit a vein for whatever reason, or the animal is not big enough and you cannot get enough blood to create serum, and then you're stuck there with an eye that is melting in front of you. Serum can be stored usually up to 6 months in the freezer, and you can use dog serum you can use serum for one dog for another. The same for cats. You can use a dog serum for a cat. Using cat serum for another cat is a little bit risky because there are certain infectious agents that we can potentially transmit from one cat to another. So I would primarily use the serum from a dog to treat other cases. But you can have a couple of bottles in your freezer and then be more relaxed when you have to treat with these cases. Again, the antibiosis is based on what you can see in your cytology. Yes, most of them will be due to Pseudomonas, but some of them might be sterile, and then we don't need to use exocin, or some of them will be a complication of the beta hemolytic Streptococcus, and you need to treat it a little bit differently. I cannot stress enough the hospitalization bit. There are cases that you will do your best, and despite that, they will deteriorate. And I don't feel comfortable sending any of these cases, any actively melting cases at home. This is a case that was presented to us a couple of years ago, and the ulcer was affecting probably 20% of the stroma. These were two superficial areas, and it's nothing that doesn't seem like anything too bad. But even with hospitalization and medication every hour, this was the cornea 24 hours later. Everything was missing. This is the stroma that is left, that is still quite infiltrated. We're almost down to decimates here, and that's even with the best care. So it is very important to hospitalize these cases to provide the best possible care. And then finally, the ugly ones, the corneal perforations. Usually they present with this jelly-like appearance at the center. This is a fibrin clot. Once the aqueous comes in contact with the environment, it creates this clot and try to self-seal the eye. Of course, at some point, this clot will dissolve and the eye will start leaking again. So these are true emergencies that require urgent surgical management to stabilize them with everything that we discussed before, either a conjunctival graft, a corneal conjunctival transposition, a collagen scaffolding material, or a corneal transplantation. These are, again, true emergencies. Sometimes we might have the iris trapped on the perforation side, and unfortunately, some of them are often irreversibly damaged. Here we can see part of the iris protruding and a lot of hemorrhage inside the eye. There is a very large rim of a melting corneal ulcer and a very large perforation. And without wanting to sound pessimistic, there are a few things that we need to assess before we discuss any surgical repair for these cases. And the important things to assess is, does this dog have a menace response? If they have a menace response, that's brilliant. There is a good indication to repair the eye. If not, do they have a pupillary light reflex, or at least a consensual pupillary light reflex, showing us that the retina is working to an extent? or if not, do they have a dazzle reflex? Do they respond at all to light? And this is because when an eye becomes perforated, there is the sudden decompression can lead to sudden retinal detachment, and it is a major consideration when we're trying to repair such an extensive damage, because we need to give to the owner some prognosis in terms of potential visual outcome and what would be the future of this eye. So that was just a brief overview of the canine corneal ulcers, and we will briefly move on to feline ulcers before discussing any questions. Now, in cats, we are presented with similar corneal ulcers, so we do get the superficial ones. Of course, we do get again the melting and the complicated ones. Of course, we get the deep ones that are down to Descemet's membrane, but in cats we do see a larger proportion of traumatic incidents, and that's because they do go outside and they're not supervised. They come back to the house with a sore eye, so trauma is much more prevalent in cats than it is in dogs. Not to say that the other ones are not common. Of course, we do see them all the time, but trauma is a little bit more common in cats. And of course, any of these cases left untreated, or even if you treat them, they can still go on to develop a corneal sequestrum. A corneal ulcer left for weeks or months can end up changing and developing to a sequestrum, a necrotic part of the surface of the eye that usually will require some form of surgery to remove. Some of them can potentially slough off. They can exfoliate as long as it's not growing deep to the cornea and not causing any other complications. You can potentially monitor them, and you don't necessarily need to surgically remove them. However, in cases that like this one that is associated with some degree of malacia around the corneal ulcer, this one has developed a very severe anterior uveitis as well. These are cases that we do need to manage surgically to try to alleviate some of the discomfort. Some considerations, species particularities, as we discussed, they are hunters. They go out, they fight with other cats. They do silly things. They fall from trees. They damage their eyes. So trauma and cat fight injuries are far more prevalent in cats than they are in dogs. They do suffer from infectious diseases as well, and herpes virus is the big one. We tend to blame quite a lot of things on herpes virus, but it might not always be the case. And then all of us occasionally will do this eye panel to screen for other infectious agents like mycoplasma or chlamydophila or anything else that the lab tests for, and we potentially will get something positive back. But herpes will cause or will complicate corneal ulcers. Usually, the rest of the infectious agents don't tend to cause corneal surface disease. Yes, they can cause conjunctivitis, they can cause uveitis, they can cause other things, but it is rare to see them causing a corneal ulcer. So just to touch a little bit on feline herpes virus. The two most important things to say is that on surveys they've done, at least 95% of the cats have been exposed at some point of their life to the virus. So they have been in contact with the virus at some point. Some of these cats will develop latency, and it can reach a percentage of up to 80%. So effectively, what this means that there is a very high possibility that any cat you're presented with has been infected with feline herpes virus at some point of their life, and this virus is latent to the trigeminal ganglia, and it is waiting to be reactivated. Some cats will never have a problem, and some others will have persistent problems, but we have to be based on case by case. And PCR and tests can be potentially a guide, but you have to take the results with a pinch of salt. We do get many false positives and false negatives, so you do need to correlate that with your clinical examination. And there are a few characteristic things to look for to try to diagnose herpes virus, because it can be a complicating factor even for superficial corneal ulcers. So the pathognomonic feature is that we have this, it's not very obvious without a lot of magnification, but we have this dendritic appearance of the corneal ulcer that is moving like the branch of a tree. We do have stromal keratitis in most cases, and yes, we can have conjunctivitis and quite severe ocular signs in terms of pain and blepharospasm. Other things to look for is other areas for discharge, so nasal discharge, potential sneezing of the cat, or previous history of recurrent ulceration or weepy eyes, recurrent problems. These are things to try to guide you towards your diagnosis of feline herpes virus. The management for most of the feline ulcers is the same as for dogs. The general principles of a broad spectrum antibiotic, exercise restriction, and keeping the cat indoors, which can be challenging, applies. A sodium hyaluronate based lubricant is far more important in cats because especially when herpes is complicating things, it can affect the goblet cells of the conjunctiva as well. So sodium hyaluronate will replenish the cells, will help these cells to repopulate. So it is even more important in cats than it is in dogs. But we do need to balance the amount of drops we're using with the stress levels of the patient. Obviously, feline herpes virus is something that can flare up in stressful events, and if applying drops 6 times a day is a stressful event for the cat, we have to manage this as well and potentially limit the amount of medication that we're using in some cases. But again, you have to be guided on case by case. The one thing to mention for cats, we are often presented with these superficial corneal ulcers that don't tend to heal. We do avoid doing grid keratotomies in cats. You can definitely use a cotton bud. You can use a bandage contact lens to try to stimulate the healing of the ulcer. But grid keratotomies have been associated with development of corneal sequestrum, so it is something to avoid. If corneal ulcers are stubborn and they will not heal on debridement with a cotton bud or with application of a contact lens and symptomatic treatment, we might need to look for underlying problems, or in some cases we do need to consider a superficial keratectomy to address the problem. And when you have cases that herpes virus is indeed causing part of the problem, there is benefit on using antiviral medication. There are topical formulation like Vergan that has some efficacy, but it has to be applied at least 5 times a day to have a bacteriostatic, a virostatic effect. And then you do have oral formulations as well. If you have alongside the ocular signs, if you have nasal or upper respiratory tract signs as well, you can use famciclovir. BOVA provides this paste. It's a bit like Marmite. Some cats will love it, some cats will hate it. Most cats hate it, to be honest, but you can try it and see if it will go well with the cat. The problem of oral famciclovir, either the paste or the tablets, is that they are not cost effective at all. You have to use them on a dose of at least 45 milligrams per kilogram twice a day, and for a medium-sized cats, going on the minimum, which is usually we go between 45 and 90 milligrams per kilogram. If you go on the lower dose for, let's say, a 5 kilo cat, you might be looking at 200 to 300 pounds for a 21-day course. So cost is often an issue with these cases. I think that's everything that I want to discuss today, and I will leave it up to you for any questions, or I don't know if we've had any questions already, Luke.